ethical considerations, prior knowledge, enough evidence of efficacy should not be superior. What do you mean? What do you mean in this case? Usually in clinical trials, since the researcher is not only observing, he or she are asking the patient to take a drug or not take a drug. This is why we cannot do a clinical trial on something that we expect that might be harmful. In other words, I cannot ask a patient to take a drug if I suspect that this drug might cause cancer, for example, right? So I should have enough evidence of efficacy. What does it mean? It means that I should know, or I should have information about the drug to be effective. In other words, it should be having enough evidence that it is a good drug, okay? But what if you have superior evidence that the drug is good? In other words, if it is superior. So if there is a new drug that is established to be a superior, a very good, best drug in the field, is it ethical to do a clinical trial? The answer would be no. Why? Because when you do a clinical trial, you will give this superior drug to people, but you will give the inferior drug to other people. It is not ethical to deliberately give some people the inferior drug where there is a better drug for their disease. This is why a clinical trial is carried out in a shaded area. If this is the evidence, if you have good evidence, and this is superior evidence. Now, if you do not have good evidence over here, you cannot do a clinical trial. Once you establish good evidence, this is a place where you can do a clinical trial. But once you have superior evidence, it's not ethical to do a clinical trial anymore. Now, somebody might ask me, how can we establish a good evidence? I'll tell you, there are so many different things that you can do. Animal studies are one of them. There is clinical trials that are called phase 1 and phase 2, which means before you introduce the drug into the market, there are some volunteers who volunteer to be part of the study as experimental people, and you will do that study on them. Informed consent. What does informed consent mean? Consent means agreeing. If you want to do a clinical trial on some people, you have to make sure that the patients included into your study agree, right? Or consent, or sign a form saying that they agree to be part of your study. But there's a word called informed. In other words, you cannot give a patient a letter written in English if they do not know how to read English and tell them, please sign the consent, right? It has to be informed. It means that the patient has to understand what's going on, what are the risks that they are running, and so on and so forth, and they agree to that, and accordingly, they will sign the consent the informed consent form. Might be difficult since patient might be confused about randomization around time of diagnosis. When you want to do a clinical trial, before you start working with the patient, you have to ask them to sign. But they are sick people, they are coming maybe to the hospital and so on and so forth. They might not really understand what you're talking about and research and so on. So they might refuse to sign the consent, and by refusal, they cannot, you should not include them into your study. Early stopping rules. Any clinical trial has to have a very clear stopping rules. In other words, if I do a clinical trial for 2 years and I want to recruit 500 patients into vitamin E, vitamin C clinical trial, for example, okay? I should not wait till after 2 years when I recruit the 500 patients and then see what's going on. Otherwise, I might have a major problem, but I do not see it during those 2 years. So what happens is I have to have data monitoring and safety committee. What does it mean? It means that maybe after 6 months, I will analyze the data that I have and see maybe mortality is increasing in one group, or maybe side effects are more in another group, and so on. So I have to have very clear indication when to stop the study and how to continue, and so on and so forth. Randomization is a very crucial, important part in any clinical trial, and it eliminates the possibility of knowing what the assignment of the next patient will be. In other words, if I leave people, or for example, if I want to do a clinical trial and I want to give vitamin C and E to one group and the placebo to another group, if I do it according to my own will, okay, I might tend to be biased. What does it mean? It means that I might give this vitamin C and D to maybe healthier people. Why? Because I think they will benefit more from this drug. Or I might give it to younger or to more males and so on. So eventually the two groups will be not equal. They will be different in terms of their age and their gender and their physical activity and so on and so forth, which introduces the confounding bias that I talked about, which I will explain later. So this is why I have to have an equilibrium, a balance between the two groups, those who are taking the drug and those who are not taking the drug. The best way to guarantee this balance is by something called randomization. So I do not decide whether this patient is going to take the new drug or the old drug or the placebo. I leave it to the random effect. So there is this process that's called randomization, which I will ask the computer to give me, let's say, a list of numbers, random numbers. And I will say any even number, the patient will take the new drug. Odd number, the patient will take the placebo. And when the patient comes in, I will see what number they have, and I'll assign them to placebo or intervention. And this way, I do not introduce this bias, and I expect that the two groups will be equal in their characteristics. Now, the critical element of randomization is the unpredictability of the next assignment. So I should not be able to predict what the next person will take. Advantages: eliminates conscious bias, selection bias by the investigator, averages out unconscious bias, which is confounding. In other words, the two groups are going to be equal. I'll explain it in details. Groups are alike on average. Thus, the two groups, those who are taking the drug or the placebo, have similar characteristics. Disadvantages: ethical issues. Sometimes it's not ethical to do a clinical trial, and thus you cannot randomize. Interferes with patient-physician relationship. When you have a patient into your clinic, you decide what to give them, the drug or no drug. But when I want to do a clinical trial, you as a physician has nothing to do with that. I, as a researcher, I'm the one who is deciding whether this patient is going to take this drug or not. So I'm affecting the patient-physician relationship. Administrative complexity, because I have to sometimes hide the information whether the person is intervention or placebo, and this is called blinding. I will talk about it. And because whenever I have a patient, I have to call maybe a center that they will tell me this patient is intervention or placebo. There is some complexity from a logistic point of view and an administrative point of view. So randomization is done to assure equal distribution of characteristics. Each subject will have same probability of taking the intervention. So each person has the same probability of being in either group. Done by hand or by the computer. I can do it by hand. The simplest way is to toss a coin. You remember, tossing a coin is heads or tails. So it's 50%, 50%. I'll have a patient coming in. I do not decide. I'll flip a coin. If heads, the person will be intervention. If tail, the person will be control or placebo. So this is the very basic, but there are computers that they will generate a list of random numbers. There are randomized and non-randomized clinical trials. So some clinical trials are randomized, some are not randomized. Of course, randomized clinical trials are superior, are better. To assess whether randomization was successful in having comparable groups, we assess the equality of treatment groups with regard to baseline characteristics, example demographic. And this is why in any clinical trial, table 1 is going to be a comparison in age between the two groups, comparison in gender, comparison in diseases, and so on. So I have to verify in table number 1 in any clinical trial that the two groups are equal to each other. Mechanism of randomization: the worst type of randomization if the investigator performs it. So if I'm the researcher, I'm the principal investigator, and I want to do the randomization, I should not do it myself, because I might be introducing some bias even if I want to randomize. The best is central, independent randomization center, such as clinical trial coordinating center. In other words, there will be a center where they will have all the randomization information. I'm sitting in my clinic, a patient comes in. Whenever I say that the patient is eligible, I'll call the center and I'll tell them I have a patient. What should I do? They will look at their programs and they will tell me, okay, this patient is going to be intervention. Okay? So this is a centralized randomization. And whenever you are critiquing a clinical trial, if you are reading a clinical trial, and you have to pay attention to randomization. How was the randomization done, and so on, because different ways of randomization might affect the validity. Sequenced and sealed envelopes on site. Other way, you do not have to call. Maybe you'll have envelopes in front of you that are sealed, closed. So you have a patient coming in. Whenever you want to include the patient, you'll open the envelope and you'll say, okay, this patient is intervention or control. And sometimes we use web-based randomization. So on the web, sophisticated clinical trials, they might have on the web, especially if it is a multi-center. What does multi-center clinical trial mean? It means that it's not only in one center, it's from different centers in the world, maybe from different continents. So simple randomization, we have simple randomization using random number table. You have something else called block randomization, and you have something called stratified randomization. These are more technical aspects of randomization. I will not go in details about them. Blinding is that certain persons do not know the treatment assignment. Blinding, by definition, is when you hide something from you. You cannot see it. So basically, blinding in research in a clinical trial is when you hide the information from people. So the people do not know what's happening. So the aim is to reduce participant and observer bias, which I will discuss. This is of particular importance when the outcome is subjective measures such as headache. In other words, if the patient, you are treating headaches with a certain drug, a new drug. If the patient know that they are taking the new active drug, they would feel better just by the fact that they know, right? So what I do is I hide from them this information. I do not tell them whether they are taking the active or the placebo. So this way I blind the patient from the information of the drug. So if I blind the patients, it's called single blinding. And sometimes I have something called double blinding, which is patients and the investigators. Why do we blind the investigators? Why do I hide the information from the investigator? Because as an investigator or a researcher, if I know that this patient is taking the new drug, which is suspected to be better, I might oversee any problem. I might not focus on the problems. This way, I'm introducing the bias just by the knowledge that I know that this person is taking the new active drug and this patient is taking the passive or the placebo, right? So this is why I hide it from the investigator or researcher. The third type of blinding is where you have triple blinding, where the patient is blinded, the researcher is blinded, and the statistician is blinded. So even the one who is analyzing the data, I will not tell them what is the active and what's the passive. I'll just tell them 1, 2, right? So that the statistician will not keep on analyzing and analyzing and analyzing till they get favorable results. Now, of course, clinical trials could be open labeled or not blinded. What does not blinded mean? If you're doing a drug versus surgery, you cannot hide it from people that whether they are doing a surgery or taking a drug. So it is obvious for the researcher, for the statistician, and for the patient whether they are taking the drug or doing the surgery. So sometimes you have to have a non-blinded or open-labeled clinical trial. Comparison group, sometimes I have no comparison group. In other words, I take a drug, give it to people. That's it. And I see what happens. This is called uncontrolled. There is no control. But sometimes there is controlled, which means I'm comparing the new drug to standard therapy, to the old drug. Or I'm comparing it to placebo, meaning no drug. So, of course, controlled clinical trials are better. In terms of analysis, there are two concepts. Assume that this is drug A and drug B, and I'm looking at relief of headache. Okay? Relief of headache. After some follow-up, maybe after 2 months, 3 months, whatever, assume that drug A, 5 patients did not take any medication. Okay? Because if you give a drug to a certain group of people, do you expect that they will take the drug for sure? Absolutely not. So this is a compliance aspect. So in drug A, 5 patients did not take any medication. But 2 patients took drug B. So they flipped. Although you gave them drug A, but they took drug B. And in drug B, 3 patients did not take any medications, but 3 patients took drug A. So there are 2 things that I can do here. It is called efficacy and effectiveness. If I'm interested in the efficacy, it means that I want to see people who took the drug, what happened to them. So when I'm talking about efficacy, I want to take only those who took the drug. So if a person took the other drug, I will not consider them in drug A. I will consider them in drug B. And if patient did not take any drug, I will take them out. So if you work out these numbers, I will end up with 96 people eventually took drug A, and 96 people took drug B because of the switching. So this is what I will analyze, and it's called efficacy. I'm interested in the effect of the drug itself on those who take the drug. Now, sometimes I'm interested in the effectiveness. What is effectiveness? Effectiveness is if I give the drug to 100 people, irrespective of some of them do not take it, some of them switch, some of them take it non-consistently, and so on, I want to see what happens. So I take the people as I have assigned them at the original design. So I gave 100 people drug A, 100 people drug B. This is how I will analyze the data. So those in drug A are in drug A, those are in drug B and drug B. Now, so the efficacy is potential effect of treatment, whether treatment can have an effect on the outcome. Compare subjects according to the treatment actually received. Exclude subjects who complied poorly, switched over, or withdrew from the study. Whereas the effectiveness, it's the actual effect of treatment in the real world, where you have people who comply poorly or change treatment. And this is called intent to treat. When you do the analysis or when you read the paper, a clinical trial, if you read intent to treat, it means that they have taken the effectiveness aspect. So advantages of clinical trial: reduced biases, selection, information, and confounding. You have disadvantages. It might be impractical or unethical, and we have discussed that. It could be expensive because most clinical trials, or a big chunk of clinical trials, you have to reimburse the patients. You have to pay money for the patients, right? And you have to follow them up, and you have to monitor, and you have to do so many things. This is why it is an expensive study design. Generalizability. Usually, generalizability is affected in clinical trials because when you do a clinical trial, you exclude some people by exclusion criteria. You say, okay, I do not want any young patients. I do not want pregnant women. I do not want elderly, and so on. So eventually, when you do a clinical trial, it will be a very unique group of patients, and it's hard to generalize. Now, I'll ask you a question. Assume that you are doing a literature search and you found 5 studies, 3 clinical trials, 1 case control, and 1 cohort on the same topic, the topic that you're interested in. Okay? How would you conclude? Which one would you believe? One study is giving you a positive answer. Another study is giving you a negative answer. And the third study is giving you neutral answer, meaning no association. So what would you do? Would you take the best or the worst or a combination of all of them? If you can think of a combination, this is absolutely right. And this is why we have a study that's called a systematic review. What does a systematic review mean? It means that I would like to combine different studies. In any topic, because we have more research that's being carried out, you have multiple different studies. So what people can do is they can bring maybe 5 or 6